Some 15 years ago, 16 years ago, in 1994, the international community met in Cairo to discuss the very important issue of sexual and reproductive. Conferences have been held, resulting in development and adoption of various declarations and conventions at the continental level, and indeed in Ghana. I mean, we're all party to this process. Some of these declarations and conventions are the Maputo Plan of Action, the Abuja Declaration, in which governments pledged to allocate 15% of national budgets to improve health outcomes. And then we also have the protocol to the African Union Charter on the Rights of Women in Africa, the Continental Policy Framework for the Promotion of Sexual and Reproductive Health and Rights in Africa. More recently, our governments met again and adopted or developed a campaign came up with a campaign to reduce campaign need for family planning. You know, supplies are not usually available in areas where they are most needed and whatnot. But I'm sure the speakers today will give us a lot of the statistics. Home-based deliveries remain significantly high, putting the lives of many women of reproductive age at risk. The rural-urban disparity in healthcare provision remains uneven, as available statistics show that 84% of urban births are likely to be delivered at a health facility, compared to only 43% in rural areas. So it's not a wonder that, you know, people continue.
Permit me to make reference to the UNDP's recent reports on beyond the midpoints.
And I would want to say that government has put in quite a lot, but perhaps we ourselves, as service providers, have to examine ourselves more critically and see whether we are also committed to achieving the MDGs or not. One thing that we are sure is that we know all the challenges. I don't think any of us in this hall can say that we do not know what the challenges are. We know them very well. If you take first, for instance, the socio-cultural barriers to accessing health, we know them. We know that women in most communities in this country do not control their reproductive health. I mean, they don't have that right. It's controlled by the spouse. What are we doing about that? I mean, through the National Health Insurance Scheme, you'd realize that the premium has been set very low to enable as many people as possible to enroll. And with the current approximately 60% coverage of the population, and also with the free maternal health services and free care for children, this is one of the social protection mechanisms we can say have been put in place to ensure that we will be able to achieve the MDGs 4 and 5. Additionally, we have also embarked upon the CHIPS initiative, and this is meant to ensure that we actually get a minimum package of service to the very rural people to bring pregnant women to where they need the service. So it is hoped that the National Ambulance Service will come in to fill in this gap. We are also working with the National Health Insurance Authority. We have come up with some draft tariffs for ambulance service so that the ambulance service can operate more efficiently than it is now. And the good news is that a memo has been submitted to Cabinet and approved. So we'll be sourcing a loan from Germany to bring in 146 ambulances before the end of this year. The referral system is also to be improved. Under the auspices of the Interagency Leadership Committee, a team was put in place that has worked on a new referral system, which is to be rolled out also this year. And on the human resource challenges, the certificate midwifery program is going to be reintroduced starting this September. And so far, 6 schools have been identified which will start that program. So the community health nurses who are in the rural areas will be brought in to undergo this training, and they are already used to the rural areas, and they will willingly go back to those places to work as staff midwives, which is better for us, as the diploma midwives come out and they don't want to go to those places. It's interesting. Then also, to improve upon the distribution of doctors to the northern part of the country, the Human Resource for Health Division at the Ministry has undertaken an initiative of sending all those doctors who have returned from the Ukraine, China, and are unable to pass the professional qualifying exam, is still 11% of total government expenditure, which means we are still far away from the Abuja target. And this clearly implies that government needs to put in more money into the health sector, which government is not doing. If you look at our current budget, 96% of our budget goes into what government gives us goes into item 1 and 4. And only 4% is available for items 2 and 3, that is administration and service purposes. So government is more or less paying us to sit down, because the health sector salary, the wage bill is high. So all government's effort goes into paying us. The 4%, which is for this administration and service, is so small that we cannot do much. And that is why we say we are literally being paid to sit down. So item 1 alone is taking about 92% of all government expenditure on health. Of course, this does not include national health insurance, which actually is for the clinical care inputs. And really, you cannot call that part of, quantify that as part of what is available for us to work in terms of improving upon maternal health or child health. It is promised to achieve the Millennium Development Goals, but we also have to be committed, after making that promise. So we should rather make it promises and commitments, because we need it too. Mr. Chairman, I believe that the MDGs are attainable. And I believe also that the actions leading to attaining these targets present unique opportunities for us to build vibrant and sustainable health systems for our people. And it's possible. We can do that, but it's for us ourselves to change, and to change our work culture, change the way we do things, the way we see things. And of course, there's no reason why we cannot attain the MDGs. Thank you.